Hi, everyone. Can you let me know if you can hear me? Just send me a reaction. Thanks, Dr. Sylvia. It's good to see you. Okay, we can start, I think, with whoever is here. Good evening, everyone. Good morning also, and good afternoon to those of you who are in different time zones. Welcome to our webinar on understanding burnout in healthcare. We're going to look at the global perspectives and the local realities. My name is Tomika Zeru, and I'm going to be your host and moderator from Visionary Healthcare Consultancy Services. We are delighted to have you with us tonight. Before we start, I'm just going to go through some housekeeping. Please keep your microphones muted during the presentation to avoid background noise. Feel free to use the chat option to communicate with us. Let us know your thoughts and your reactions. We will have a Q&A session at the very end. You can post your questions in the Q&A section, and then we will deal with it time permitting at the end of the session. We will be recording the sessions and sharing the recordings with all the registrants. If you are joining today and you haven't registered, you are very welcome. We are very happy that you are here, but just let us know your details by registering in the chat. I will post our contacts and a link, and you can either shoot us an email or send us a WhatsApp with your details. We promise we won't send any spam, but we will just keep you informed about upcoming sessions. So it is my great pleasure to introduce our keynote speaker, Dr. Colin West. Dr. West is originally from Seattle and received his MD and PhD in biostatistics from the University of Iowa in 1999. He completed his residency and chief residency in internal medicine at the Mayo Clinic and joined their faculty in general internal medicine in 2004. He is currently Professor of Medicine, Medical Education, and Biostatistics at the Mayo Clinic in Rochester, Minnesota, USA. Dr. West is Director of the Mayo Clinic Program on Physician Wellbeing and was named the first Medical Director of Employee Wellbeing for the Mayo Clinic in 2022. His research focuses on medical education and physician wellbeing and has been widely published in prominent peer-reviewed journals, including The Lancet, the Journal of the American Medical Association, and the Annals of Internal Medicine. Please join me in warmly welcoming Dr. Colin West. Dr. West, the floor is yours.
Wonderful. Thank you, Dr. Zeru. I really appreciate the invitation to speak with all of you at the end of what for many of you, I imagine, has been a busy day. So thank you for making the time. I'm going to take just a moment here and share my screen and cross my fingers that the technology works the way it did 10 minutes ago when we tested it. All right, so Tamika, can you give me a thumbs up that you can see my full slide? Should be my title slide right now.
Yes.
All right, very good. Okay. Excuse me. So first of all, I'll start with my contact information. This will be repeated at the end of my talk today as well. My email address, a few social media connections. I do post a well-being thread every Wednesday. If you're interested in taking a look at that over time, it's been going on for nearly 5 years now on a weekly basis. This is a two-part series. The second talk will be in a month or so. And across the two talks, there are really three overarching learning objectives. We'll discuss the scope of the problem of clinician distress. We'll talk about why this matters, what are the consequences, And then as we think about what the solutions are, both locally and globally, understanding what the contributors and drivers of this problem are will be essential. We'll then turn to what the frameworks for solutions look like based on that understanding. So in this first session today, we're going to focus on building that foundation, make sure we have a common baseline to understand what is the scope of this issue, what are we aspiring to, what do we want in our health professions, what do we know about the consequences, and how can we set the stage for part two's conversation about solutions by understanding what drives both distress and well-being. So that's a little bit of the roadmap for what we're going to do today. And again, when I come back to visit with you in a few weeks. The images on the screen here illustrate what all of us in healthcare, no matter where we practice, no matter whether we're in a clinical role or in an administrative or other supporting role in medicine, want in our work environments. We want positive human relationships with patients, with colleagues, with families, with our communities. And I think it is true for almost all of us that much of the time, we actually are able to experience these kinds of relationships. But it is also true that these are challenged. And sometimes these relationships are not what we experience. We don't have the resources to deliver the care that we need or that we want to for our patients. Sometimes our patients are hurt, scared, angry, in pain, suffering. And sometimes we don't know how to help, and we have our own stress, and we have our own baggage that we bring into these relationships. So as we try to reach this level of well-being illustrated by these images, it's worth thinking about sometimes the gap between what we experience and what we hope for, which leads to the question of, well, if we're aspiring to well-being, what does well-being even mean? And it turns out that this is a little bit difficult. Getting everyone to agree to a very specific definition of well-being is a challenge. I will share my own working definition, which has guided my work at Mayo Clinic. It is very broad. My working definition of well-being is the state in which an individual can achieve their greatest desired potential as a complete human being. This is not specific to work. This is not specific to healthcare. But there are certainly elements of this that our work in healthcare should embrace. There are aspects of our lives outside of work which affect our well-being overall. There are aspects of our lives at work that affect our well-being overall. So as complete human beings, work is one element of who we are. Well-being is about achieving that greatest desired potential across all of our domains. Now, I mentioned that we don't experience complete well-being in all of our interactions in our lives or at work. We hear a lot about distress. We hear a lot about burnout, especially in the last decade or so globally. Burnout has become a commonplace term, and it often gets thrown around and misused a bit. Oh, I had a bad day. I'm burned out. I'm tired. I'm burned out. Burnout actually has a specific definition. As developed over multiple decades by researchers such as Christina Maslach and Michael Leiter in the United States and in Canada, burnout is a work-related phenomenon. It's a syndrome with three main components: emotional exhaustion, depersonalization, and a sense of low personal accomplishment, all of which lead to decreased effectiveness at work. This is not specific to medicine. In fact, in the initial work that these researchers did, they weren't even thinking about medical applications. Later on, they involved nurses to validate their theories. And we've done a bunch of work about expanding this to physicians and others in healthcare. So, what are these three dimensions that contribute to burnout or are part of what burnout is? Well, I'm going to say just a bit about low personal accomplishment, and then I'm going to put it to the side because in our early work, this was not associated, for physicians at least, with important consequences. We're going to have to come back to that because there's more recent research that is putting that into question. But low personal accomplishment is this idea that the work that we do doesn't matter. We, despite being highly trained, very intelligent, dedicated individuals in medicine, sometimes feel that despite all of that, the work that we do doesn't matter. We're not making a difference. We're not doing everything that we could or should. We could be doing more. And so we tend to diminish our sense of what we are personally accomplishing. I mentioned this has not been associated, at least in our early work, with important consequences. However, it relates closely to concepts like imposter phenomenon and low self-valuation. And there is emerging research to show that those are associated with important outcomes, which suggests that low personal accomplishment we may need to revisit as an important factor. The other two are emotional exhaustion and depersonalization. Emotional exhaustion is illustrated by this statement. This comes from the Maslach Burnout Inventory, what many regard as the gold standard for assessing burnout. I feel like I'm at the end of my rope. This is emotionally feeling like you have nothing left to give. You are husked out. You cannot connect with your patient's emotional needs. Certainly, as we try to engage with patients in medicine, it's a problem if we feel like we can't tap on emotional reserves to meet those needs. Depersonalization is illustrated by this statement. I've become more callous toward people since I took this job. This is treating other human beings as objects, becoming desensitized to their human experiences. And again, this is not consistent with any model of professionalism that all of us in medicine hold dear. So it's a real problem when we start to feel this way. Now, technically, these are all measured on basically continuous scales. For ease of communication, we have demonstrated in our work that if these feelings are experienced at least once a week, that is associated with a host of important consequences that I'll speak to in a moment. But keep that boundary in mind. If emotionally you feel like you have nothing left to offer, if you've become more callous toward people, at least once a week, having those feelings, that's a marker of burnout experiences that are problematic. Now, before I talk about the frequency or prevalence of these issues in medicine, I want to revisit a bit of where we've been across the globe in the last 5 years. What's shown on the slide here is an illustration of what are known as the phases of disaster response. These were originally developed as experienced by communities, but they also apply to individuals. And in the last 5 years, the disaster that impacted us globally was COVID. Now, we have had other challenges, disasters, crises across countries, but COVID affected everybody. And prior to 2020, we have some data on what's been going on with burnout. Things changed in 2020, and the pattern requires that we understand how healthcare responds to a crisis. So when COVID began, there's this impact point. And somewhat unexpectedly for many, in the early months after COVID hit, we actually saw across medical communities burnout levels go down, not up. Upon further reflection, that is thought to relate to this heroic and honeymoon phase of disaster response. We're all banding together, taking care of people who can't take care of themselves. We are running toward a problem while we're telling everyone else to run away from it. That can be very bonding for healthcare professionals, but it's also not sustainable. And when that continues for too long, we enter a phase known as disillusionment, where well-being actually gets worse, burnout gets worse, and then over time, we gradually rebuild. So with that in mind, the data that we've seen in our national studies across the United States follow this trend quite well. Prior to 2020, we saw burnout prevalence numbers of 45 to 50% across United States physicians. Those numbers were important because in the United States, at least, prior to national data, there was a mindset that physicians who experienced burnout were suffering from some form of individual limitation or deficiency. They weren't tough enough for the profession. Maybe they chose the wrong profession. They weren't cut out for the rigors that medicine requires. When you have prevalence numbers of 45 to 50%, that mindset simply cannot be true. And in fact, we all know we chose healthcare because it's challenging, but we are gritty, we are tough, we deal with challenges, and we try to adapt and reflect those challenges back in our work to help our patients, to help our colleagues. In 2020, about 6 months into the pandemic, we saw lower burnout rates. And again, we were initially surprised by this, but it aligns with the disaster response model. We didn't feel like we could wait 3 more years with the frequency and cadence of these surveys, though, after that 2020 survey, because the environment as 2021 rolled on did not feel like we were having lower distress. So we resurveyed in the United States nationally later in 2021, about 18 months into the pandemic. And we saw the highest burnout levels that we had ever recorded, over 60% nationally. And in certain areas, like in the intensive care units and in the emergency departments, we saw burnout rates among physicians of up to 85%. We also saw for the first time in the United States that other healthcare professionals, our nurses, mid-level administrative managers, saw very high levels of burnout as well. Historically, in the United States, physicians have had higher burnout levels than other health professions. That has changed. And as of 2021, we were sort of all in the same boat. Now, as the pandemic sort of wore down, we have seen, based on data in 2023, that burnout levels have also come down. I don't have a slide to show you this, but in pockets of national data around the rest of the world, we have seen a similar pattern. I did do a little bit of a lit search in the last week or so about data coming out of Namibia. I found a little bit in obstetrics departments, a little bit around nurses, not a national global summary though, so I can't give you great data about what's going on in your own local environments, but I will say that this phenomenon is a global one. There is no health system or country in the world that is immune from this, and the patterns, although they differ a bit from country to country, are generally fairly consistent. So in the United States, what this means, if we take these numbers from national data, is that we have more than 100,000 trainees in medical pathways, 500,000 physicians, more than 1 million nurses dealing with burnout experiences that are problematic, plus all of the other healthcare and biomedical science professionals. So these are big numbers in the United States. The proportions, 40, 50, 60% of our healthcare professionals dealing with this, are eye-catching. So certainly people should expect to have learning and working environments that allow them to thrive. Why else should we care about this? Well, it turns out that there are consequences no matter which group you care about the most. So from a patient care standpoint, we know that burnout is associated with medical errors and suboptimal care. It's also associated with suboptimal professional behaviors. So things that we hold as cornerstones of being a medical professional are eroded when we are experiencing burnout. No surprise, patients, especially over time, are less satisfied when their physicians are distressed. And there are even studies showing that implicit and explicit racial biases against minoritized groups are worse for healthcare professionals who are experiencing burnout. Importantly, when those health professionals recover, when their burnout is alleviated, their racial biases also improve. We are not our best selves when we are experiencing burnout. It matters not just for us, but for our patients. It also matters for our healthcare systems. So we know that burnout is associated with staff turnover, reduced clinical hours, early retirement, and we know from limited national studies from countries outside of the United States that burnout is associated with people departing their home country, looking for something better elsewhere. Doesn't mean they always find it, but this is critically important as countries seek to retain their own talent, their own skilled professionals in their own national interests. We also know at an individual level that burnout is associated with mental health concerns, fatigue, motor vehicle crashes, and important deficiencies in medical knowledge acquisition. So in one large study, we demonstrated that trainees experiencing burnout performed on standardized examinations a full year of training behind residents who did not experience burnout. A full year of training in medical knowledge acquisition or performance on standardized testing. When we look at costs, in a study we did with the Harvard Business School in the United States about 10 years ago, so the numbers are out of date at this point, we found that for physicians alone, just looking at the costs of job turnover related to burnout, this was costing about $5 billion US dollars a year, about 7,600 US dollars per physician per year. And I looked at an exchange last night, and this equates, obviously, economy scales differ from country to country. But if we converted the US economic environment to Namibian dollars, this would be 130,000 Namibian dollars per physician per year that burnout is costing the US healthcare system, at least, in physician job turnover related to burnout. So not considering other health professions, not considering other consequences of burnout. This is very expensive for our healthcare systems. And right now, we're not accounting for it. I'm not aware of any health system that actually includes in its economic modeling burnout or well-being in its healthcare system finances. So we are paying for this as a system without really paying attention to it. And I mention that because often in resource-constrained systems, we hear we would love to address well-being, but we have so many competing priorities, we simply can't afford to. And my response is just understand you're already paying for not addressing well-being. It's not that you can't afford to address well-being. You can't afford not to address well-being. There is always something that can be offered to improve the learning and working environments for the people that are taking care of your population. So again, these numbers make this question on the screen really not a real question. Is this rooted in individual deficiencies, or is this a system problem more deeply? Now, the truth is, the responsibility lies in both areas. And we're going to talk about that more as we get into solutions during the next talk. But I just want to make this point now that historically we have thought about well-being primarily as an individual issue, when the larger component actually comes from our systems. The pendulum swings to system responsibility, and then I'm going to swing it back just a little bit to say, yes, and as individuals, there are things we can do that we can control when we can't control all of the system around us. So we should take responsibility for what we can while we're working to improve our systems. There is a roadmap for dealing with large system problems and rethinking how we approach a problem that historically we have put onto individuals. Quality and patient safety gives us a guide. So in the United States in 1999, the Institute of Medicine, what is now called the National Academy of Medicine, issued the report To Err is Human. This turned our approach to patient safety on its ear. Prior to this, the most common approach to dealing with errors and patient safety in the United States, and I would suggest across most of the world, was to identify who was responsible for the mistake, correct them, punish them if necessary, and impress upon them that they had violated a professional responsibility. So in training environments, we would have M&M rounds, morbidity and mortality rounds, where people would be brought up on stage to basically be humiliated. They would never want to make an error again because of that experience. And everyone in the audience would be cringing, thinking, oh, yeah, don't want to be there. And the idea was, oh, yeah, people are going to be more responsible, more dutiful. They won't make errors. We know that fear can be a good short-term motivator, but it is a very poor long-term educational strategy. To Err is Human came along and said, wait a minute, the vast majority of people in healthcare want the best for their patients. They're not trying to make mistakes. They don't want to make errors. And yet, when an error happens, we're making them feel worse. What is it about our systems that is not protecting patients and medical professionals from human fallibility? Deming, who is an august figure in quality and patient safety, said that 85% of the reasons for failure relate to systems and process rather than the individual employee. So he advocated, let's fix the workplace, not the worker. Paul Batalden at the IHI in the United States has said every system is perfectly designed to get the results it gets. So on the one hand, if we have a healthcare system that doesn't work the way we want it to, well, it's designed to do that. We created it that way. That's not a very positive view of much of our healthcare across the world. On the other hand, however, I prefer to think of this not so negatively, but in a way that it reflects an opportunity. Because if we're committed to designing a healthcare system that promotes well-being for our healthcare professionals so that they can help patients in the best possible way, well, our system will get those results. We can design the system to deliver the results it is going to deliver. So how do we think about the drivers to get us to that kind of a system? At a very high level, one of the simplest models to think about distress and well-being in medicine is the job demands resources model. This model says that when there is a chronic imbalance between high job demands and inadequate resources, that leads to distress. Now, the trick in medicine is recognizing that everything we do is high demand. Even the simplest clinical decisions that we think we're making just as a reflex, there are years of training. There are thought processes going on. Is there a side effect? Is there going to be a complication? Can my patient afford this? When is their follow-up? Can they meet a specialist if they need to? All of these decisions are happening cognitively behind the decision. We get really good at making hard things seem easy in healthcare, but the demand, the cognitive strain is still there. We've done studies in the United States that show that the task load for physicians across different domains is higher than almost any other profession, including in many areas, heavily manual labor-oriented professions that everyone understands are high demand, difficult, draining kinds of professions. There is a cognitive load, a task load in medicine. The demand, the numerator pushing down on well-being is ever present. That means that we need resources to match those demands, or we need design changes to alleviate those demands where we can. But what happens in medicine across the world is that we are asked to do more with less. We are asked to be more efficient. Resources are pulled back. We have people working in multiple job roles rather than just their core training function. And we do it because we're committed to our patients, of course, but the outcomes are predictable. According to Job Demands Resources model, that can drive distress. This aligns with what we know about human performance. So on the left on this slide is the Yerkes-Dodson law. I'm not going to talk about the simple task dashed line because we just spoke about how tasks in medicine aren't simple. For difficult, complex tasks, the Yerkes-Dodson law shows that we respond with better performance up to a point under stress or stimulation. But as human beings, as that stress or stimulation continues for too long at too high a level, our performance actually declines. We do not deliver optimal performance in those scenarios. Physiologically, we have many analogies for this. In the center is a variation of the Frank-Starling curve, cardiac physiology. We know that if we have inadequate filling pressures, we have suboptimal cardiac function. We also know that if we overstretch our sarcomeres on the right side of that curve, we also have suboptimal cardiac function. There is a zone in the middle, just right, end diastolic pressures, where we have optimal cardiac function. And the human stress response curve is no different. We chose medicine because we respond to stress and stimulation. We like that challenge. That promotes performance to a point. But across the world, so many of our healthcare professionals, as evidenced by the prevalence data I shared a few minutes ago, are not functioning optimally on their stress response curve. They are sliding down the wrong side of this curve where they are chronically exhausted and they need help. To optimize our performance in healthcare, as individuals and as healthcare systems, we need to think about how we shift our place on this curve. Getting a little bit more specific here, I mentioned Christina Maslach and Michael Leiter a bit ago. They have also outlined 6 areas of work life, as they call them, that drive burnout or well-being. These are not specific to medicine, but they apply to medicine. These are not secrets. I think if any of us got together with a few colleagues, in 5 minutes, we could generate this list. But it is backed by 4 decades of research. Workload, not a surprise. When workload is sustained at too high a level for too long, in alignment with human performance theory, we have increased risk of burnout. Now, in medicine, we're not talking about workload increasing from, say, 20 hours a week to 30 hours a week of work. We're often talking about the difference between 50, 60, 70 hours a week of work, which in other professions, at least in many countries, is a level of work that very few professions can match. It's hard work with long hours, high demand, high stress. That workload can drive distress. Control and autonomy are important. In medicine, we are highly trained, and in many healthcare systems, despite that high training, we are subject to many regulatory limitations. And in some areas of the world, people even feel, even in the United States, people feel like they are told how they can practice without having autonomy. Reward is important. This is both intrinsic, the reward we get from being in healthcare, and extrinsic, what comes from outside of us. We'll talk about this more in a moment. A sense of community is essential, being treated fairly and with respect, and having our individual values align with what we see in the healthcare system around us. So I'll spend just a few minutes digging into each of these in a bit more detail. When we think about workload, again, we need to think about sustainable human performance. The Yerkes-Dodson law, its adaptations, not just in larger human physiology, but on our stress response curve, is essential. We're not talking as healthcare professionals about having vacations at work. We actually like being busy. We like helping people in challenging situations. But often we're asked to do that for too long at too high a level of strain. We need team members then to help us with that demand in the job demand resource model. So as you have teams helping with care of patients, everyone needs to be working to the top of their skill set to the extent that resourcing allows you to have that team. And I recognize this is a challenge in many parts of the world, that the teams themselves are incomplete. Having a culture of shared commitment and teamwork and doing things that matter. So in the United States, there's an initiative that was published in the New England Journal of Medicine. Initially, it comes from a health system in Hawaii called Getting Rid of Stupid Stuff, GROSS. And the idea here was looking at your clinical practices and looking at the things that are causing cognitive strain that your teams are doing that they don't need to be doing. They're not essentials. Because when you are overtaxed, the essentials need to go, or the non-essentials need to go, so that you can dedicate your cognitive energy to what is truly essential. Now, that's different in different practices, in different countries, in different health systems. So you have to think about, in the United States, for example, I mentioned we have many regulatory requirements. Electronic paperwork forms, signing things. We have common discussions about, well, does this need to be signed by a physician? And often the answer is no, but it's still landing on the physician's desk, in addition to 300 other tasks that they are supposed to do. The same thing happens for our nurses and for other people. And so thinking about what is truly essential and trying to get rid of the things that are not. I mentioned control and autonomy. So as healthcare professionals, having some voice in how we take care of patients and in our work days, determining team processes as teams, rather than feeling like we are simply told what to do. Engaging healthcare professionals in leadership decision making so that nothing happens in healthcare without the people actually doing the work being involved in those decisions. Intrinsic and extrinsic reward, I mentioned. It's important to recognize and demonstrate that every person on the team has a key value in our larger mission in healthcare. We need to be intentional about how we recognize individuals. And part of that is compensation and pay and salary and benefits. But some of this is also about demonstrating appreciation and gratitude in ways that cost nothing. We have a bad habit in many of my own teams of taking the excellence of our colleagues for granted when we only comment when something doesn't go right. We rarely comment when things go well, to express appreciation or to honor somebody for the great work that they do. But it means everything to people to be recognized for the great work that they do. No matter how humble someone may be, I can tell you, we all have an ego, even if we try and suppress it. It feels good to be recognized, and we are surrounded by people doing incredible things all day, every day. That is a very simple, and it's not just inexpensive, it's free way of improving morale and well-being across an entire team. And one other aspect to this, when you express genuine appreciation for someone around you, it actually makes you feel better too. It lifts everybody. It is important to actively engage every member of the team. I like to tell my teams, feedback is a gift. I may not like the feedback. I may not even agree with it, but it is a gift. A consultant in the United States named Tim McClure wrote to leadership organizations that the biggest concern for any organization should be when their most passionate people become quiet. So encourage people to share ideas, to talk with one another, and encourage people to be balanced. because not everything is perfect, but not everything is terrible either. And if people can balance, hey, we identified a problem, here are some potential solutions. Can we work on those? That's great. Can we also recognize, here are some things that are going well? Here's why I love my job. Here's why I love my team. And have I mentioned that to you recently? We can do more of that. Regarding community, connection is essential. Belonging within a team and across a healthcare system is really essential as we do the difficult work of medicine, whether you are working in a clinical role or in an administrative role. Groups need to have their space to bond together. There needs to be space for teams to bond together. And I can share, at least in the United States, I can't speak for Namibia or a lot of other settings, but in the United States, physicians often feel isolated, separated in their work. We have a study coming out in the next month or so demonstrating that in the United States, physicians have more loneliness and social isolation than other employed members of the population. The work that we do can be isolating if we don't intentionally lean into the community around us. Being treated fairly and with respect is essential. There is no hierarchy of respect in medicine. We sometimes are in systems, many of us trained in systems, where there was a strong hierarchy. That does not apply to respect, even if it applies elsewhere. Everyone deserves respect. Most of us are familiar with the golden rule, treat others as you would yourself be treated. One of my esteemed emeritus colleagues used to teach us about what he called the platinum rule. This is a little different than what you see as a platinum rule in business. But in medicine, he said the platinum rule was not treat others as you would yourself be treated. He said the platinum rule is treat others as you would want a loved one treated. And I think we can apply that for our colleagues in medicine as well as to our patients. And then values alignment is largely an organizational responsibility. As individuals and as organizations, we need to be clear about our values, and then we need to make sure that we are acting in alignment with them. These principles have been adapted to a medical audience. In the United States, a paper from Mayo that came out in 2017 really took these drivers and reframed them around medical experiences. These differ from health system to health system. For example, in the upper left, in the green, efficiency and resources. In the United States, almost everyone will immediately jump to, well, our electronic medical record-based system is in many ways inefficient. In other countries, I understand it's less widespread, if present at all, in Namibia, an electronic medical record isn't really the problem. You have different efficiency issues in your medical care delivery. I can tell you when we had paper-based medical record systems, one of the efficiency issues was being able to gain access in a ready fashion to old charts and historical records on patients, to be able to shape a care plan with full knowledge of what had happened in the past. That's much easier with an electronic medical record system. But there are other aspects of our electronic medical records that are problems. So what efficiency means is different from structure to structure. At the center of this, however, is meaning in work. And this aligns whether this is a medical job satisfaction sort of construct or within medicine itself. If these drivers are less optimal, that pushes to distress. If they are more optimal, it pushes us towards engagement and well-being. But my contention, after working in this field for more than 20 years in well-being, is that every effective solution to promote well-being works by augmenting our ability to connect with meaning in work. In fact, I have called these the MVPs of well-being. So in the sports world, an MVP is the most valuable player. So playing on that, the most valuable players of well-being, the MVPs, meaning, values, purpose. Every effective solution for well-being connects healthcare professionals with meaning, values, and purpose in some way. So in the United States, when we work to improve the efficiency of our electronic medical record by reducing the amount of typing I need to do on a screen to enter orders, that is helping me connect with well-being, not just because I'm typing less and maybe less at risk of carpal tunnel syndrome. It is helping me connect with well-being because it's allowing me to put more of my focus directly on my patient. I'm not distracted by the computer or by things that are separate from what matters the most. And when I'm working with my patients, what matters the most is that relationship with my patient. Meaning, values, and purpose. And I don't think it matters what healthcare system or structure you're in, what your resources are, what your environment is, what your organizational value statement is. Meaning, values, and purpose are what drew all of us into healthcare in the first place. It's why we do what we do. And when we work in settings that connect us better with these MVPs, we are more able to flourish and thrive. Before I stop for this part one, I'm just going to link this slide here, and I'm going to make the PDF available to Dr. Zaru as well. This is a slide that shows links to a bunch of solutions. This is a teaser for some of what we'll talk about next week or in a few weeks. There are many organizations, especially in the United States, that have developed rosters, if you will, of solutions. And these can be practice-oriented, these can be education-oriented. But it's important, I think, because what works best in your own practice, in your own setting, in your own country, is going to be somewhat unique and locally determined. It can be important to get a sense of what the broad universe of solutions looks like, and then be able to think about, well, does this make sense for our needs? And some of these well-established solutions, you'll look at and say, yeah, not relevant to us. And others you'll look at and say, yeah, it's actually kind of a big deal for us. For example, something that we've done at Mayo Clinic in recognition that community is so important is that we've developed physician groups that meet periodically. And they have a topic list that is oriented around common physician experiences. And as part of these meetings, they discuss these issues in a safe, protected way that no one else has any insight into. It builds community, it builds problem solving around common experiences in medicine. And we've got randomized trial data to show that that improves meaning from work, it reduces burnout. And after 10 years, we have more and more physician groups that are signing up to be part of these over time. We'll see more about how we link solutions to some of this framework of contributors and drivers when that's the focus of the session in a few weeks. But I'm going to stop there, I think, for this session. Again, my contact information is here. If you're interested in my weekly Wednesday well-being thread, and by the way, I have no monetary connection for any social media platform. I'm not verified or business approved for any of them. So don't worry about that. But if you're interested in sort of, what is the dialogue around well-being issues? Again, I post every Wednesday. The links are here. Also happy to have anyone reach out to me at any time. I'm going to stop sharing my screen now, and I will hand it back over to Tomika to moderate any questions, comments, or other discussion points that anyone would like to share. Thank you for your attention. I know it's in the evening where you are. If it makes you feel any better, I still have a whole half a work day to go myself. So you're a little ahead of me in that regard. Hopefully you'll be able to get some rest and recovery. Thank you for your time, your attention, and I look forward to seeing you again in a few weeks. Dr. Zaru, I'll hand it back to you.
Thank you so much. Thank you so much for your presentation, Dr. West, and I feel so much about what you said because it resonates. And just seeing that there's actually a structured and systematic way of defining burnout, understanding that it also happens in countries where there is where we sort of believe there's so many resources, there cannot be burnout, sort of giving us that big picture and letting us know, that there is something that can be done about it. And hopefully we can think about this and then come together in a few weeks' time and sort of think this through. Now, I'm going to just open the floor for questions and answers. Questions and answers. I've seen that maybe the Q&A is not working, but you can post in the chat or you can unmute yourselves and ask a question if you would like. Any questions? I'm sure there's a lot to digest.
I see a hand raised. Is it
France.
from France?
Okay, can you unmute yourself?
Yes, great. Thank you. Thank you, Doctor, and thank you, Dr. Colin, for that presentation. For me, I'm currently a student, and my topic is more of your work. So my topic is exploring the effects of staff shortages on nurses' mental well-being at Okahanja Hospital, that is in Namibia. So of your presentation, I am busy with data collection and the reasons I am getting, or the answers that I'm getting, and forming part of my themes and sub themes are really of what you have discussed, even though I want this in the Namibia context. So hence this would really help me, and I would want to have the PDF presentation with me, Dr. Tomika. So thank you very much.
Thank you for those comments and important work that you're doing, understanding the Namibian experience. So there are these global understandings of drivers, but how they operate at a local level requires local work. So what you're doing to understand the mental health experiences in the local environment is very important. Wonderful that you're doing that work. And if I can help in any way with the presentation in helping with that structure that Tomika mentioned, I'm glad to do that. And as I mentioned at the beginning, I'll be sharing a PDF of my slides here just as soon as we're done. I will email that Dr. Zaru's way. And then I'll let her figure out how she's going to post this and share it with people. But we'll make sure that you get that. And if there's any other difficulty with that, I'm just going to put into the chat here again. It was on my last slide. But again, if there's any difficulty with any of those postings, my email has been posted now in the chat, and I can send you a PDF of my slides directly.
Thank you very much, Dr. Colin. We appreciate that and keep on doing the good work, France. We need a lot of data that still needs to come out of Namibia. So any other comments or queries?
I see a couple things. Let's see. Justine, go ahead, and then there are a couple of Q&As that I'll
Thank you
get
so
to.
much, Dr. Colin. A very topical topic. And I think it's something that most of us are suffering from. It's just good to know that there's actually work has been done around it and there's actually solutions to it, and that we can explore these solutions and just bring it back home to the Namibian context. So yeah, all the things of you're not strong enough, you are not resilient enough. I think we've grown so much into it and it's really affecting our mental health. So it's really good to know that there is a way out before it's too late. Thank you.
Yeah, I very much appreciate those comments. And I think there is a culture shift in medicine that has taken a very long time. but the sort of old way of almost a survival of the fittest mentality, what in the United States we've called a macho mentality, which is I'm tougher than anything you can throw at me, and I will not admit that I have ever struggled in any way. It leads to people feeling like when they have those feelings, they are the only one. When the reality is, the numbers suggest that if you look to your left and you look to your right, at least one of those people is sharing your experience. But we don't talk about it. And we all know medicine is never going to be easy. It's not a simple profession. But the challenges we can share with one another. We do not have to bear them alone. And so I see a comment in the Q&A about feeling guilty about looking after ourselves. This is part of that cultural mind shift. Self-care is not selfish. In fact, you have to take care of yourself to be able to be effective as a healthcare professional. And one of the, I've had people question that. And one of the examples that I give is, for anyone who flies on airplanes, part of the safety presentation at the beginning is they show you that, if there's a problem, the oxygen masks will drop down from the ceiling. And they always say, secure your own mask before assisting others. They say that because if you're in a low oxygen situation, you can't help anyone if you don't have oxygen. You need your mask to work before you can help those around you. Our work in healthcare is like that. We've got to be present for ourselves to be able to be present for others. And we are kidding ourselves if we don't think that that applies to us, if we think that we are above that, because we are first and foremost human beings. As much as sometimes we like to pretend that we're superhuman, we are human beings. And so I think, avoiding the guilty feelings, it's tough because we also are very self-critical. We hold ourselves to very high standards. And we know, sometimes we're going to be tired and we're going to need to push through. Sometimes, things aren't going great, but I have other patients that need me. We need to give ourselves some grace. We also need to work in systems that recognize it's okay to be human. It's actually part of what makes us better able to treat and care for others. And that's a culture change. And it's something that every country in the world is dealing with to an extent. But we have to evolve. And the old way of thinking, pretending that these problems don't exist, doesn't allow us to solve them. And if we want a thriving healthcare workforce, we have to recognize that it's challenging work. It will hurt us at times, but we can also be part of each other's healing. Where should I go next, Tomika? I see a couple more in the Q&A, and then I think Dr. Harui's hand is up as well.
Okay, so I think you've answered sort of two of the questions where somebody is asking, how do we actually deal with the guilt of looking after ourselves? You've also already dealt with that. And then there was another one that also along the same line said, how can we prevent burnout when we have to work under a lot of expectation and understaffing? And I think you've dealt with those. So I'm just going to
let me just say a quick word about the understaffing issue, because I don't want to minimize that.
Okay.
We face that in nursing units in the United States, especially since the COVID-19 pandemic. We have actually many hospitals that are understaffed in the United States as well. And I know this is internationally, this is a problem. It's something in the United States we used to think we would never have to deal with. We are dealing with it now. Mm-hmm. And I'm not going to give you a simple answer to that because it's a real problem. Mm-hmm. How do you deal with burnout when the workload is not sustainable? We talk about human performance theory. Well, figure out how to adjust the workload for optimal performance. Well, what if no one's adjusting the workload? Now I've given you a solution that no one's going to implement. And so I'm not going to pretend that I have a good answer to that. but I will just challenge the healthcare system as a whole, as a nation. This is beyond any of our control individually. But at higher levels of decision making, people need to understand that when you are chronically under-resourced and understaffed, you are setting up your healthcare workforce for distress and suboptimal performance. They will continue to do their best for as long as they can, because healthcare professionals are committed to what their patients and communities need. But we need to be working as systems to try to provide the resources. Again, back to the job demands resources model. If the demands are going to stay high, we cannot reduce the resources. Those are very difficult problems to solve as an individual healthcare professional, because you're on the shift doing the work. But they are ongoing questions and challenges for higher level decision making to recognize, oh yeah, this is an issue we need to deal with. And that is the first step, because you'd be surprised how many health systems I talk with who aren't even willing to acknowledge that they have a staffing limitation, let alone that it's a problem. So again, the first step is awareness. And as an individual, when you're understaffed, overstretched, one of the first principles is recognize that in yourself. Be mindful of where your boundaries and limits are. And if there are other things that you are doing that are not optimal, oh, I'm under stress, so I'm going to make this up. I'm drinking too much, or I never exercise, or whatever it happens to be. There are things within our individual control to help our well-being that we sometimes need to lean into even more when our system isn't optimal, while we are working to have our system help us.
Thank you so much. I think we can all relate to that. That really resonates. I have another question from an anonymous, it's an anonymous question, quite deep. Thank you for the good presentation. And I'm currently going through burnout, being a resident and working at the same time. And this is affecting my performance, of which perhaps I find it hard coping with work overload. What advice would you give this person?
Yeah, so the first part of my response is make sure that people that find themselves in this situation often feel very alone. They feel like they are the only ones who are struggling, and that is never true. And so make sure that you, sometimes it feels like, well, I'm struggling, so I'm going to actually turn into myself. I'm going to become more isolated. This is exactly the time when people need to actually reach out and make sure that their community, their connections, their support network is active. Because what people usually find is everyone's got challenges. The people who say that they don't have challenges are pretending. Now, some people do have, they have different coping strategies. They cope a little better than others, and that's true. There's a spectrum for this. But it is exceedingly rare for somebody to be the only person who's experiencing a challenge. So that's one part of it. The second part of it is, I think, understanding that, what are the potential pathways to help cope with the amount of work that someone is dealing with? Are there inefficiencies? I work with medical students quite a bit. And we commonly have medical students who say, well, geez, I'm seeing too many patients in a day. I can't keep up on my documentation. Documentation is a big thing in the United States. And oftentimes we sit down with them and say, well, every note that you're writing when you see a patient, you're writing a 10-page essay on this patient's presentation. No one wants to read 10 pages. Guarantee you that the surgical services are not reading 10 pages of your summary. So maybe you can help the teams around you and yourself with some efficiency tips that you don't actually have to be doing quite as much in the way that you're doing it and yet still provide great patient care. Sometimes it's, well, I'm trying to work as hard as I can, and the only way I can do that is by getting less sleep. But the less sleep you get, the less able you are to function. And so you start a downward spiral. And sometimes it means stepping back and saying, you know what? I need to take care of myself, get my rest so that I can be the best I can possibly be when I'm at work. I need to reverse that downward spiral with what is within my control. Those are a couple of examples. They may or may not apply to an individual because everyone's got their own unique circumstances. But sometimes just knowing that you're not alone is helpful in its own right. And so I really encourage people, whether you're in training or in practice, really foster that community, that network of trusted colleagues where you can share experiences, share solutions, and recognize that you're not alone. This is an honorable profession, but it's also a demanding profession. And it's a very hard profession to survive alone. We need to lean on each other.
Thank you very much. That is very, very true. Dr. Hirui, I see that you had your hand up a while ago.
Yes. Thank you, Tomika. Thank you, Dr. Colin, for the wonderful presentation. It's very great presentation. So amazing. Do you hear me?
Yes, thank you. Thank you very much.
Yes. Okay, let me continue. Well, you made a good summary of burnout, emotional exhaustion, depersonalization. You just gave us briefly as is. I think there is nothing left from what is any health personnel is experiencing in life. And as you have mentioned, the under-resourcing and understaffing will end up poor performance. Then the poor performance expectations are met. Expectations are not met. And then it has a snowball effect at the end of the day, disappointment and even not satisfaction by the community. So when we see in such situation, in your side, there is enough resource, there is enough manpower, but still there is something which is not corrected globally, I can say, the long working hours, the endless working hours. It makes people exhausted physically and mentally. Then it ends up into depression and stress. Now, what do you suggest? Of course, from this side, the resource and the manpower is the biggest problem, and the expertise is the biggest problem. And the combined effect of all these things, it will end up to dissatisfaction, because every time that you see minus here and there. So as a consultant, can you think of something that can be like something that fits in different places according to the resource and according to the availability, to me, that can minimize the stress and mental exhaustion? Anyway,
Yeah, so
it's just
thank you for the question. It's a very challenging question, and we'll talk more in a few weeks about a sort of menu of potential solutions that may get at this a bit. I do think one of the first steps, and I'm going to just acknowledge that this is not a solution, this is preparatory to a solution. One of the first steps is we have to be willing as health systems to assess the well-being of our healthcare teams, and then leadership and health ministers and people like that. They need to then recognize, okay, our health system, we have outcomes for our population. Sure, we track those, but we also need to have outcomes for our health care professionals, the people who actually deliver the care. And are we going to hold ourselves accountable to that as a health system as well? Once you do that as a health system, then you're able to say, okay, our our doctors are reporting working 70 hours a week. They are reporting sleeping 5 hours a night. That is not sustainable. We need to think as a health system about how are we going to control the workload given what we're seeing. But if you never assess the experience of your healthcare professionals, if it's all rumors or potentially viewed as just, oh, a few people complaining, then it's really hard to get energy behind solutions. So assessing the state, and so what Franz mentioned at the beginning about, you know, the experiences of nurses in a particular environment, that kind of work is really important. And then you need to have leadership nationally that is interested in the experience of the healthcare workforce, because they recognize that Namibia's health depends on the healthcare workforce. If you can make those steps, then some of the solutions that I'll talk about in a few weeks will be better supported. And so that's where I would start. Understaffing and excessive workload often go hand in hand, because when you're understaffed, the people who are working have to do more. Those are hard problems to solve without more people. There's really only two ways to do it. Number one, you either have to get more people, or you have to find other ways, whether it's through automation or simply not doing certain parts of a job that are not essential, other ways of reducing the demand. So you reduce the workload. Those are really the only two paths forward. And the structure of care that we deliver depends in large part on what your health ministry and your government sets as the standards, hopefully in consultation with healthcare professionals themselves, people like all of you. We'll talk more about that in a few weeks, I think.
Thank you.
We are over time, Dr. West, but there are two hands up. How do you?
If you're willing to do those, we'll do the two hands that are up, and then maybe we'll wrap there.
Awesome. So, Berhe.
Good. Okay. Thank you. Actually, I don't have a question. I just want to say thank you to Dr. West, number one, for your kindness, for presenting this presentation, and for sacrificing all your time despite your busy schedule. Thank you very much. And my thank you also goes to Dr. Zaru for enabling us to listen to what Dr. West presented and for organizing this forum. I really want to express my appreciation. Thank you.
Thank you very much.
Thank you. Absolutely my pleasure. And I also just want to, my thanks to all of you and my appreciation to all of you for the work that you do to help patients and communities, often in difficult circumstances. But this is why we all work in healthcare. We want to help other people. And we're part of a global family in doing that. We all work in different environments. We have different resources, different backgrounds, different practice settings, but we are joined by a common mission, hope and healing for those around us. And it fills my cup to share thoughts with people like all of you who are so dedicated to the well-being of others.
Thank you for that, Dr. Colin. Christian, you had your hand up? Christian?
Looks like maybe we're okay.
Okay. So I think we can wrap up there. Thank you, Dr. Colin, for a very insightful, very impactful, very informative session, and also for reminding us of why we are medical professionals and why we are in the healthcare field, because sometimes we can forget. Sorry? Okay, I think it's just somebody clapping. so it's a good reminder. It's good to know that there's hope. As has been mentioned, in about 3 weeks' time, on the 21st of October, we are going to have part 2 of this webinar series where Dr. Colin goes into solutions and strategies. What can actually be done? And I think from his presentation, the one thing that we can take away is this is not a one-time fast solution. It's something that needs
David,
it's some
there is a myth. Did you see it?
It's something that needs commitment, needs work on, community. And I think we can think about what we've heard today. And then when we come together on the 21st of October, we will find ways on which we can handle the challenges in our workforce. Thank you very, very much, Dr. Colin, for this presentation. We really appreciate you and all the knowledge that you have brought. Thank you very much to every single person that has joined. We really appreciate the time that you have spent with us, and we hope that you will be with us for the second session. If we can get CPD points, we will try. We will try and get, it's a thank you. We will try and get CPD points, but we look forward to hearing from you. We will send you a recording and also the PDFs for the presentation. Thank you very much, everyone. Have a great evening and good afternoon, Dr. Colin. Good morning for those who are logging in from where it's morning. Thank you.
Thank you all.
Goodbye.
Thank you.
Thank you.